Good afternoon. Thank you for the opportunity to share the work we are doing at the University of Wisconsin in Madison, developing a structured extended training program to facilitate adoption of new techniques for practicing surgeons, or what we call Project Adopt. This program is made possible with funding from Medtronic. However, both the project and this presentation are entirely independent of any product influence. As all of you know, laparoscopic inguinal hernia repair is associated with similar rates of recurrence compared with open repair. However, it's been found to have lower rates of chronic groin pain and earlier return to work and normal activities. Despite the benefits of the laparoscopic approach, it remains underutilized in the US and abroad. In a survey of Canadian surgeons in the Ontario province, the laparoscopic approach was only utilized in 8% of all cases. Even in situations where it was recommended, such as bilateral inguinal hernias, it was only utilized approximately a quarter of the time. In fact, a large proportion of surgeons never perform any laparoscopic inguinal hernia repairs whatsoever. So a separate survey performed by the same Canadian group addressed some of these barriers to laparoscopic repair, and of the 46% of surgeons studied that never performed laparoscopic inguinal hernia repair, 70% felt there were minimal benefits compared to the open approach, and nearly 60% felt they lacked appropriate training to perform the procedure. A quarter of the respondents were interested in learning the technique, and the majority felt that the best approach to education was a course followed by expert preceptorship. So while there are a plethora of courses available to learn the technique, there's little help to provide the surgeon beyond these courses, and this has likely led to the underutilization of laparoscopic repair in practice. So we hypothesize that a structured program involving simulation, hands-on training, and surgical coaching would facilitate adoption of laparoscopic inguinal hernia repair for surgeons in practice. The project goal was to critically evaluate the implementation and development process for a newly designed CME level course for laparoscopic total extraperitoneal hernia repair, or TEP. So we aim to recruit 3 surgeons currently in practice with baseline laparoscopic skills, but who currently perform open inguinal hernia repairs and have a case volume of more than 50 inguinal hernia repairs annually. 2 surgeons who are TEP experts were trained to serve as surgical coaches using the Wisconsin Surgical Coaching Program. And using an iterative process, we developed a curriculum incorporating simulation, intraoperative training, and surgical coaching, and assessments were created to monitor each stage of the program. The orientation day incorporated didactic and procedural teaching, including video-based review and a written assessment. A simulator was used for a baseline assessment of the participants' operative skills, and surgeons were then introduced to the principles of surgical coaching and given the opportunity to go over their performance on the simulator with their assigned coach. The next stage involved gloves-on training, where the participants scrubbed in with a procedural expert to observe and perform TEP repairs in the expert's operating room. The next step was followed by the surgical coach precepting several cases in the participant's local operating room, and the final stage of training involved live video-based review of the participant's first 10 independent cases with their surgical coach. Upon completion of the program, participants returned to UW for a final simulation assessment with their surgical coach and an exit interview. So 2 of the 3 surgeons completed all aspects of our training program. 1 surgeon completed the program in 5 months, while the other took 7 months. Our last surgeon had yet to complete several aspects of the training when our funding ended and the program was closed. For the surgeons who completed all of the steps, both were still using laparoscopic repair as their preferred method of repair nearly a year after completion of the program. And they reported that their preceptorship and coaching sessions were the most valuable aspects of the program. So in conclusion, we do think that a structured program can help facilitate incorporation of laparoscopic inguinal hernia repair into practice. But this was a small pilot study, so more data is needed. The program does require significant time commitment as well as a reasonable case volume, and coach-coachee scheduling conflicts were a major deterrent in the program completion. Our aim now is to transition this type of program model so that it can be disseminated on a larger scale. I'd like to acknowledge our entire Project Adopt team at the University of Wisconsin in Madison, and thank you again for the opportunity.
Questions? Yes.
Thank you for that presentation. I think the ADOPT program is an absolutely magnificent way to get surgeons in practice to learn new skills. So I run a fellowship, and I can tell you that, and Dr. Ramshaw will agree with me, my fellows learn how to ruin my gastric bypass before they learn how to do a proper TEP. How many cases, on average, did the surgeons say they needed to do, either under your direct supervision, before they felt like they knew what they were doing? Do you have that number?
We have that number anecdotally based on our interviews with them and surveys that they completed throughout the course of their participation in our program. And it really varied between the three surgeons based on what their prior experience had been and their case volume. One of our surgeons, the one who actually completed the program in 5 months, felt he was very confident after he had completed half of his independent cases, and his coach, really agreed with him. They had met several times during the course of reviewing those first 5 independent cases on video, and the coach actually had recommended that he didn't really need his help anymore, but the coachee wanted to finish the course and was quite comfortable with his with the skills he developed by the end of his time with his coach. Our second surgeon, who took 7 months, really asked for more help even after he'd completed the course, and had returned at 6 months follow-up with him. He said that he had felt more comfortable with TEP after he completed about 25 cases independently.
Yeah, my sense, having trained fellows for the past 14 years, is on average, the fellow in my hands needs somewhere between 15 and 20 cases before I feel comfortable letting them go independent.
So do you have a sense of what the coachees felt was the one major difficulty from an operative perspective, and then did that correlate with what the coach thought that person was being challenged by, operatively speaking?
Operatively speaking, I'm sorry, I'm trying to recall from our surveys from the program. The coachees really felt that it was more about being shown by a TEP expert the right way to do the procedure in general, and then to be able to follow through with that on their own. When the coaches went to the coachees' operating room and observed them either in person for their preceptorship or even by video in some cases, I think the biggest challenge for the local operating room was to not, and for the surgeon, the TEP expert, was not to change the feeling in the operating room, because they were an outsider watching what was happening and therefore affecting the surgeon's performance. But in terms of specifics within the case, it was really about getting familiar with the equipment and getting the steps of the procedure down in the right way and following through with that.
And no more questions. Thank you very much.
Thank you.